Hi, I'm Dr. Sadie Larson, clinical psychologist and member of the ISTSS Public Information and Education Committee. ISTSS works to disseminate knowledge to improve care for people with PTSD. And as part of that goal, the ISTSS Education Committee collaborates with people who developed or implemented the interventions highlighted in the ISTSS Child Psychological Treatment Guidelines. So today I'd like to welcome Dr. Kelly Chrestman, who co-authored the manual on prolonged exposure therapy for adolescents, which was one of the psychological treatment interventions with a strong recommendation in the ISTSS guidelines. She's currently a PE subject matter expert at Center for Deployment Psychology. So thank you so much for being here today.
Thanks for inviting me. I like to talk about this treatment.
Excellent. Well, why don't we start there? Could you just tell us a little bit about the specific goals and key components of PE in general, and then we'll move towards adolescence.
Well, PE is a treatment, as you know, for PTSD, and it's based on the idea that um, PTSD symptoms are generated because of avoidance, because of the avoidance that comes from the distress people have related to the traumatic event that they had. So the longer people avoid and the more they avoid, the less they're able to process their memory and the less they're able to correct inaccurate notions and ideas that were generated by the memory. And so PTSD symptoms develop. And so PE as a treatment targets avoidance primarily and the cognitions that promote avoidance. And so we have people talk about their memory. We have people confront some of the things that they've been avoiding as a result of the trauma. And then we process those experiences. And the thing that I love about PE actually is because we're doing exposure based work, it's really an experiential treatment. People are learning while they're doing their exposures. So when it comes time to process, the learning is already there. We just have to put it into words and make it explicit. And so it works for children and adults and all across the spectrum.
And so, for people who are more familiar with doing this work with adults, how would you say that this looks different with children or adolescents?
Well, the manual we wrote is for adolescents, so people 11 to 17 or 18. And when we developed the manual, we really were what we had in mind is that adolescents are not small adults. They're not big children. They're sort of somewhere in the middle. They're constantly in flux and in transition. It's a huge developmental period, and so two adolescents of exactly the same age and background are not necessarily maturationally the same. And so
Mhm.
we wanted to make a treatment that was flexible so that we could target people who had PTSD all across the adolescent spectrum. And so we tried to scale down some of this is really is just PE. So for older adolescents who are very mature, you might not be able to distinguish it from standard PE. But what we tried to do is take the components of PE, the imaginal exposure, uh, the in vivo exposure, and the processing, and the psychoeducation as well, and scale them down across the adolescent spectrum so that the therapist has choices based on what the adolescent is presenting with. The other big change between PE and the PE for adolescents is because adolescents are minors and they live in their parents' home or they live in a group home or they live in a foster home, they're not completely autonomous. They can't drive themselves to therapy sessions often. They can't make decisions for themselves sometimes because they're limited by the law and other things. And so we knew that one of the things that stands in the way of children and adolescents completing treatment is they don't have a situation that helps them get to therapy consistently, and they don't have a situation that helps support doing the homework and the activities at home that are going to help them progress through the treatment. And so we popped in a pre-treatment phase in this treatment so that we could do some pretty decent case management, figure out what the situation was at home, figure out where they were living, how they were going to get to and from, what other kind of school activities might interfere with them going to therapy, what other kids are in the home, and what other demands are on the parents that that are going to compete for taking care of getting this child or adolescent to therapy. And we also put in a motivational interviewing component in the pre-treatment phase. And the reason we did that is because we really felt like, especially with some of the older adolescents, well, I shouldn't say that, all across the adolescent spectrum, and this is true for kids too. When traumatic things happen and they're outside our control, often when we have to go to therapy about that, it feels like we're being compelled, like we have to do it. When you're a kid or an adolescent, often you're not the one that decides you need to go to therapy. People are making you go or ordering you to go, or here you are showing up and people are telling you that you need to do these things. And we knew that motivation and cooperation with the therapy was going to be difficult with many of those situations. And so we felt like motivational interviewing was a way to really do some active listening, get the adolescent on board, really let them know that we wanted to hear what they had to say, and then put them in a frame of mind that they could actually make the choices to work on the things that were important to them, put it into their own words. So they felt like at least they had some control and some choices over what was happening to them. So the case management and motivational interviewing phase really kind of go hand in hand. They don't happen separately. But as we're doing that case management, as we're finding out about the background, we're also asking for what the adolescent thinks and trying to reflect back to them that we heard them, and checking it out and making sure that they know that we want to create a treatment that's tailored for their goals and not someone else's. So that's the major difference, is that pre-treatment phase.
Makes a lot of sense. So it's setting them up for success on the one hand, and also really getting their buy-in so that it's not just
Yeah,
something that they're being made to do.
exactly.
Yeah.
Exactly.
Um, just curious, do you ever kind of get to a point where you feel like this person just really doesn't want to be here and it's probably better not to proceed?
I think that happens, and um, that can be upsetting for parents. It's also upsetting to me,
Mhm.
especially if the adolescent is symptomatic and suffering.
Mhm.
Um, we don't have to do PE with
Mhm.
adolescents, even if they have PTSD. If they object to the trauma processing part of the treatment, we
Mhm.
can do other things. We can try and connect in other ways. We can try to sort of put that on the back burner and circle back to it when they feel more comfortable. We
Mhm.
also can do work with parents. If the parents are involved, we can try and support them in providing the kind of environment that would support healing, that would encourage the adolescents to do things that are gonna help them move past the trauma. But I think it's not a good idea to force people to do therapy when they really don't want to. Um, and those of us who've worked with adolescents know sometimes adolescents come in and sit there and they're silent and they don't really want to do anything. Um,
Sure.
Chatting often is what happens when if they're willing to chat.
Mhm.
Sometimes
Mhm.
that works. Um, Sometimes, I try to play a game, and it depends on the adolescent. Sometimes there's shyness. Sometimes there's that sort of rebellious, sort of, oppositional, I'm not going to talk to anyone kind of attitude. So I really think folks who work with adolescents and who are good at it really have to think on their feet and figure out what it is sitting there and how am I going to get around that, because kids come in because they are suffering, and often they don't know that there's a way that we can help them, and so they don't want to participate. Often there's so much shame involved because many of the things that happen to adolescents are embarrassing or uh, disappointing, and they feel shameful, and so they don't want to talk to a stranger about it. They don't want other people to know about it. They're also worried about other private things that might come out that they don't want to share with their parents or their teachers or other folks. And so trying to find a way to talk about that and how to protect that for them is important. There's just so many things that stand in the way of connecting with adolescents. I think we do have to try a lot of things before we let people just go on their way.
Yeah. But I like that focus on giving them as much control as you can in a situation where they may not always have complete
Yeah.
control.
Yeah.
Um, and you mentioned a little bit this manual, and I understand that there may be some upcoming
Yeah.
changes, updates to that manual. Anything that you're thinking about updating?
One of the things we're going to update is we are going to update the assessment section that's in the manual. And my colleague Sandy Capaldi, who's going to join us on the manual, is going to do a real thorough chapter on assessing adolescents for PTSD. The other thing we're doing is we want to clarify in that we talked about motivational interviewing in the original manual, but we really didn't give people kind of a step by step how that might fit, because this is not motivational interviewing as a treatment. It's more of a style. And
Mm-hmm.
if this were motivational interviewing, the client would be sort of sitting in the driver's seat for most of the time. And when we do PE, we do have an agenda. We do have techniques that we're going to be using. And so we're not truly doing motivational interviewing. We wanted to give people a better idea about where that sits and how to do that. The other thing that we wanted to let people know is that there's been a lot of research since the original manual. And so
Mm-hmm.
PEA has been taken across the world, and it's been done in lots of different areas. It's been adapted, it's been combined with things, it's been done on a compressed schedule successfully. And we wanted to let people know about those things too, so that they knew that those were options for their clients.
Yeah. And you mentioned typically 11 to 17. Is there sort of a lower age limit that you would think about?
Well, when we think about adolescents, they sort of maturation is not like on a line that goes in a nice
Mm-hmm.
orderly fashion. So people can look 17 and they have the impulse control of an 11-year-old, and they have the articulation and the intellect of, a 20-year-old. And so there's it's not even, they
Mm-hmm.
can have spots where they're kind of lagging behind, and especially when trauma has affected things. Um, and so I think we want to assess. We want, when we have that lower range, 11 years old, 12 years old, what we want to see is that they're comfortable talking to the therapist. They're able to be with the therapist, with their parent out of the room for some part of that time. They're able to not necessarily talk about what happened initially, because that's sometimes hard, but they're willing to take some ownership over the conversations that happened with the therapist, and that they're not needing sort of that more hand-holding approach that we might do with children that are younger. And so, there's nothing wrong with having an 11-year-old that needs that, and that's what they should get if that's how they show up. So it's not so much about the number, but more about how they present.
Yeah.
At that younger age, we do have, we can do artwork, we can do even exposure through artwork, we can have the kids write. There are lots of things we can do. And then again, they may need even slower and more gradual exposure and other things that we might do with children that just aren't necessary with adolescents.
Well, and you've talked about this a bit already, but in terms of developmental considerations, what ones do you find are important in this adolescent age range to be thinking about?
I think it, I think it's important to wait and be patient, to let adolescents show you what they can do. Um, we've had adolescents that come in and they don't talk much. They're kind of quiet. They're hesitant to tell or say things, and then you give them a pen and paper and they start writing just loads about what happened to them and what they think.
Mhm.
Um, we also have, kids um, who I try to think of a younger age. We've had some kids who had difficulty with the therapy situation. It's such an alien situation. It's kind of like, who does that unless you have a problem? And so when you're an adolescent, it might not be a familiar situation. They think of
Mhm.
you kind of like a doctor or a healthcare professional. They don't think about the talking being important. So they come in and they have a hard time expressing themselves, even in writing. My colleague, Sandy, came up with a technique for a particular client that I just thought was brilliant because she was having a hard time getting the client to do the imaginal exposure and talking her way through
Mhm.
the therapy. And so she tried writing, and the client could write, but she still wasn't very expressive. She didn't have a vocabulary to say the things that she needed to say. She didn't have, it's almost like she didn't know how to tell a story. So she had her write what she could write, and then they went through the narrative together. And Sandy would say, were you feeling something when you wrote this? Did you have any feelings? And she would say yes. And so Sandy took that narrative and based on their conversation, she took the narrative and typed it out and left blanks. And so when the adolescent said, this happened, and she didn't say much about it. She said, I felt, and then she left a blank for the client to fill in. So they had this sort of fill in the blank
Mhm.
game that they had.
Yeah.
It wasn't a game, it was about her trauma, but
Mhm.
she was it sort of demonstrated to the adolescent what we wanted her to do without giving her the words, without
Mhm.
saying, did you feel, because sometimes adolescents or kids will agree with you, especially if they're not very expressive. They'll say, yeah, I did feel sad, or yeah, I did feel afraid. And that's not really what they felt. And so what we
Mhm.
want them to do is really think. So she only had to think of one word. And so she filled in the
Yeah.
blank. The next time they did it, she put more blanks. The next time she did it, and not just about feelings and thoughts, but about the events that happened and the details of the event.
Mhm.
And they ended up coming up with this whole narrative about what happened that I don't think this young woman would have ever been able to tell had Sandy not brilliantly, come up with that intervention. And since she did that, I always try to mention it when I talk about this treatment because we didn't write that down in the book. Maybe we'll put it in the book this time. But it was just such a good use of kind of mixing the writing and the talking and really connecting with the adolescent to support them to say what they needed to say.
Yeah. So using a little bit of creativity to help
Mhm.
the patient kind of understand what what you're going for, what would be helpful to them. But I like that without putting words in their mouth or saying, did you feel
And
fear?
exactly. And I think the words are important. Like the goal is always to have them tell the story in words because there's something about putting our experiences into words that helps us, reconsolidate it and remember it in a different way, with all the new information that we've learned and our exposures kind of included in it. And so even when we do artwork, sometimes we'll have kids draw something about what happened. Some of the younger kids like to draw, they'll draw a very detailed picture of their living room or their cat or all of the things that happened. And they'll say, this is where this happened. And so we move from that and the therapist can take the details down almost like dictation. And we eventually work toward having the child tell the story while they're, pointing out the things in the picture using language so that when
Mhm.
they remember it, they're not just remembering images and flashbulb kind of memories, they're remembering the narrative. And I think that's an important piece of processing.
Mhm. That's great. Um, you mentioned a little bit ago also the some potential updates to assessment. Can you say just briefly how, if at all, that may look different with adolescents than with adults?
There are instruments that we use that are different. So there's a CAPS for children and adolescents that I think we like to use. There's the CPSS, which is the instrument that authored by Dr. Foa and by Sandy Capaldi, that is the self-report that we use for PTSD symptoms. It's good to get a behavior assessment to find out, if there are behavioral issues that are happening. Um, but it really, just like with adults, assessment is the linchpin. I mean, people who have PTSD, who had a trauma and have PTSD, we want to give them, an exposure-based treatment or a cognitive behavioral treatment that targets those symptoms. But trauma doesn't always cause PTSD. Sometimes it causes other things. And so we want to carefully assess to find out if we need to be providing a PTSD treatment or something else. Sometimes there be just behavior problems that are happening. Sometimes there are attachment issues. Sometimes depression or anxiety, or the anxiety is more generalized, and the treatment is different in those cases. And so we want to differentiate those folks from people who actually have PTSD symptoms.
Yeah, very helpful for treatment planning for sure. Um, and what kind of training do you think would be important to be able to use this treatment for adolescents?
I think that the the training that people can do, training for PE is generally more available than training for PEA. It's just a more common treatment, and adult treatments are more common in general. So people who are trained in PE have a pretty good foundation, but I think what makes this shift to treating adolescents more smooth is if you have good knowledge about adolescents and what they're like and how to treat them generally. So people who already do treatment with adolescents, maybe with other treatments or other modalities, who don't know PE, might be able to find a PE treatment and then use the manual to incorporate, because the techniques that we're using with adolescents are not different than the ones other adolescent treatments use. We're just applying them in a particular way. The other place people can get treatment is if you already have had PE treatment. Sandy does, because she's still at CTSA, at the Center for the Treatment and Study of Anxiety in Philadelphia. She does an adolescent training, I think a couple of times a year. And as far as I know, that's the only way to get training in PEA other than getting PE training and then picking up the manual. So,
Okay. Okay, that's helpful to know. And I guess last kind of broad question is just any other advice that you would have for agencies or clinicians thinking about implementing this, any lessons learned?
I think the lesson that I've learned, at least doing PE and doing PEA, is not so much about adolescents or adults, although I think people are more scared to do exposure-based things with younger people. But that is that people have a pretty significant sort of fear of doing exposure sometimes, especially if you haven't done it. It sounds very frightening. And it can be distressing for sure. When people talk about terrible things that have happened, sometimes they cry, sometimes they become, distraught because they're terrible events. And so that's an understandable reaction. But when I train people, because I do a lot of training with PE, and one of the things that I try to get therapists to do with patients is to ask them about all of the times that exposure has worked for them in their lives when they weren't doing therapy. Because exposure is not a special technique that we only do in therapy. It's actually just learning. And it's the way we learn. And we do exposure all the time when we have things that are difficult or frightening for us, and we do them because we have to. And the more we do them, the easier they get. And pretty soon we feel confident. We don't feel scared of it at all. And so I try to get therapists to ask patients, is there anything? And this is what I do in workshops. I'll ask people, what have you all done that was scary to you at first? And it's not so scary for you anymore. And people will come up with all kinds of things like learning how to drive a car, or learning how to ride a bike, or learning how to scuba dive, or public speaking is another one. And I think, once people start to realize that exposure principles are happening out there all the time, we train our kids this way. We help them get used to things. Exposure is just getting used to something so that you can, put it into context and judge it fairly and not react to it as if it's something else. And so I would encourage people to think about that and consider exposure-based therapies more often, because they work so well and they work so quickly, and we apply them compassionately and we apply them carefully. And I hate for therapists to miss out on a technique that can be so effective.
Idea of demystifying exposure
Yeah,
therapy a little bit.
demystify it.
It's learning.
Yeah, it's just a normal thing that we do. We just have a funny name for it,
Yeah.
you know.
Yeah.
I mean, it is a weird name. I wish we'd picked something nicer.
Yeah. It is an unfortunate name, but really, really powerful therapy.
Very.
And so thank you so much for just coming and talking with us today and helping to demystify PE for adolescents.
That was a pleasure. Thank you for inviting me.